all set? Cool. Alright, so we're going to go ahead and begin. Hey guys, my name's Evan Hart. I'm a physical therapist working here at Physical Therapy and Balance Center. Today, the topic of my presentation will be knee pain. Before I get into it, I just want to encourage you guys to ask questions as we go. If anything needs to be clarified, something was unclear, if you have just general questions about knee pain, or it's something you've been dealing with, someone you know has been dealing with, and you just want to ask a question, go ahead. I'll be watching in the comments on the side as we go, and as those questions pop up, I will address them. Just to kind of give you guys a brief overview of what we'll talk about today. I'll begin by talking about some of the common types of injuries that occur at the knee joint. The main two types of injuries we'll be discussing are ligamentous tears, I'm going to address the ACL tears mainly, and then we'll also talk about meniscal tears. After that, I'll talk about a few of the common causes of knee pain that are not always directly related to a big injury or an injury mechanism. Two things I'll be addressing there are patellofemoral pain syndrome, or PFPS, and osteoarthritis of the knee. To conclude, I will discuss some of the common PT treatments, the different techniques we use here to commonly treat knee pain, decrease people's pain, get them moving better overall. So let's get into it. The first thing I'll be talking about, like I said, is ligamentous tears. There are several very important static stabilizers, different ligaments in the knee, that being the LCL, the MCL, the PCL. But the main one I want to talk about today will be ACL because that is by far the most commonly injured ligament in the knee. So first we'll do a little anatomical review, kind of discussing exactly what the ACL is and how it functions. And I'll use my model here to kind of demonstrate exactly what I'm talking about. So here I have my model of a knee. I'm going to show you exactly where the ACL sits. So it stands for anterior cruciate ligament. It's not actually on here, but I'm going to point to where it would be originating and attaching. So it originates at the lateral aspect of your femur here, so it'll be originating right there on the side, passing up to the front of the knee, attaching on the medial side, the front part of your tibia. That's your shin bone there. It's called cruciate ligament because it's crossing the knee. The ACL together with the PCL also form a cross and really form majority of that static stabilizing, those features that you need to have the static stability of the knee. So the ACL provides about 85% of the stability to prevent anterior translation of your tibia relative to your femur. So that's your thigh bone here and your shin bone, and the motion that it's preventing from happening is your tibia sliding forward on your femur there. So it's preventing that type of motion and just adding to the stability of the knee. So that's how the ACL functions and where it's located. Now we're going to talk about how it's commonly injured. So there's a common mechanism that occurs when you see ACL injuries. It's a cut and plant movement that causes the ACL to tear. It usually occurs with a sudden change in speed or direction. While that foot is firmly planted into the ground, you'll see the knee kind of collapse inward. Whenever this injury occurs, the athlete that is injured will normally report that they either felt or heard a pop go off in the knee as their ACL tore. There are two main types of ACL injuries that occur, those being non-contact ACL tears and then contact ACL tears. A non-contact ACL tear occurs from, quick or uncontrolled movements. Just as a few examples, that'd be like changing directions too quickly while running or landing awkwardly from a jump. And a good example of a non-contact ACL tear that occurred in the last few years was Klay Thompson's injury. He had a non-contact ACL tear while playing against the Raptors. They were on a fast break run down the court, ran up to dunk the ball, came down just on his left leg with a lot of force and speed, and his ACL tore on him. He had to perform rehabilitation to get back to sport. Now we're going to talk about contact ACL tears. So those result from a blunt force trauma to the knee. Usually these are really high speed, high impact injuries, and whenever you have a contact ACL tear, you'll often have other ligaments that are involved with that high impact injury as well. A term you may hear is an unhappy triad injury, and that's whenever you have injury to the ACL, your MCL, and then your medial meniscus as well, because that force was just so great. In the last couple of years, a good example of a contact ACL tear occurred with Rob Gronkowski whenever he caught a pass from Tom Brady running down the field. He was playing against the Browns, and he was hit in the side of the knee really fast, really hard by TJ Ward. You could tell right away it was a real tough injury, and he had torn his ACL and also had to perform rehab to return to sport. Here, I just kind of written down a few important notes about ACL injuries. This was a fact that I found kind of surprising, that a majority of ACL tears are actually non-contact, don't involve any physical contact from outside forces. Non-contact ACL tears account for about 70% of the cases, whereas contact ACL tears are only about 30% of the cases. Another interesting fact that I found is that women are actually 3 times more likely to have ACL injuries compared to men. There are several anatomical reasons for this. One being that in general women have wider hips, and that results in a greater Q angle. This is something I'm going to discuss a little more in depth later when I talk about patellofemoral pain syndrome. But what you can think about Q angles being is the angle going down your femur, coming from your hip, attaching at the knee. The greater that angle is, the greater the forces are at the knee, and in general, women tend to have a greater Q angle, which puts them at a greater risk for ACL injury. Some other reasons why women are more likely to have ACL injuries are there are hormonal variations that increase the laxity of their joints and ligaments. So a little less stability there puts them a little more prone to injury. And lastly, when women compared to men, they have a little less muscular strength in general because of lower testosterone levels. And when they have less muscular strength, that provides less support at the knee, also putting them at a little higher risk for ACL tears. So next we'll move into meniscal tears, another really common injury that you see. Before we get into the mechanism of injury, how meniscus or menisci tend to tear, we're first just going to do a little anatomical review, talk about exactly what a meniscus is and what it does. So menisci are made up of fibroelastic cartilage, which is actually a majority, 65 to 75% water. The meniscus rests between your femur and your tibia. That's your thigh bone and your shin bone. The way I'll explain to patients is there's your femur, there's your tibia. It sits right in the middle, and it serves as a shock absorber for your knee for those high impact forces. In your knee, you have both a medial and a lateral meniscus. The important thing to note here is that the medial meniscus is more C-shaped, it's smaller, and it's less mobile, which makes it a lot more prone to injury when compared to your lateral meniscus, which is larger and more circular, which makes it more stable and a lot less prone to injury. So you tend to see the medial meniscus damaged much more often compared to the lateral meniscus. When it comes to the typical injury mechanism for your meniscus, usually involves your knee being flexed or bent, your foot is planted on the ground, and then with a twisting motion occurring. So it's a plant and twist type of injury mechanism that often causes meniscal tears. Typical signs and symptoms of a torn meniscus include joint line tenderness. So if you damage that medial meniscus, the one on the inside of your knee, you'll have some tenderness there between your femur and your tibia. And if you injure the lateral meniscus, you'll be able to feel on the outside of the knee and feel some tenderness there. Other typical signs and symptoms include clicking, catching, and locking during knee motions with occasional knee buckling, because you can picture that meniscus is that pad in between the two bones, it's a little frayed and it gets caught as you both flex and extend your knee. So that's why you get that clicking and popping sensation. Some other interesting things about meniscal injury I thought worth noting were that if you have a tear in the outer 25% of your meniscus, it will actually heal over time because there's good supply to the outer portion of your meniscus. If you see a diagram for this, they'll sometimes call that the red zone, with red referring to the blood flow that promotes healing. However, if you have a tear in the central 75% of that meniscus, you'll actually have no intrinsic healing ability for that meniscus because it's just not getting the blood supply it needs to heal, and that's why they'll refer to this as the white zone. So tears on the outer part of the meniscus heal over time. Tears on the inside, not so much, just due to the lack of blood supply. Okay, And now we're going to move on to some of the common causes of knee pain that are not related to injury, or not directly related to injury. With the first being patellofemoral pain syndrome, or PFPS. So PFPS is described as diffuse pain over the front part of your knee, your anterior knee, which is increased with activities that increase patellofemoral joint stresses. So there are several types of activities that will irritate PFPS symptoms, and those usually include things like stair climbing, prolonged sitting, squatting, and then highly repetitive tasks such as running, where the knee is constantly flexing and extending, high impact forces going through those knees for 30 minutes, an hour, 2 hours at a time. Those are going to make your knee pain worse in this case. If the issue that's causing this PFPS, this pain syndrome, is instability or lack of strength there, what can even happen is that you can have frequent subluxations or dislocations of your patella. So your kneecap is popping out of place, and you'll have a resulting pain and instability. And one other diagnosis that's similar that I felt was important to mention here is patellar tendonitis. It's another common cause of anterior knee pain. It has similar aggravating factors in that really repetitive tasks that are putting a lot of strain on the knee are going to flare up your symptoms, but the pain location is slightly different. So with patellofemoral pain syndrome, patients will often report pain either deep to their kneecap, like right underneath it, deep inside the knee, or on the sides of the kneecap, because that's where the tension and the pressure is occurring. Whereas with patellar tendonitis, they'll tend more to feel it right along your patellar tendon, which is a little lower than those other symptoms there. So it's right along your patellar tendon, just distal to your kneecap. So when it comes to discussing some of the common causes of patellofemoral pain syndrome, there are three that come to mind. It's alignment, strength deficits, and flexibility deficits. I'm going to go ahead and break those down for you. So first of all, we're going to talk about alignment. And here it's really important to look at the Q angle, that term I had described earlier, which is described as an angle formed between your quadricep muscle, that muscle running down the front part of your leg on your thigh, and the patellar tendon, which is just below your kneecap. This angle is indicative of how your legs are going to function and how they're going to work biomechanically, usually with greater angles putting greater forces on the knees. So a normal measurement for this is about 10 or 15 degrees, but in the case of someone has real wide hips or they're kind of knock-kneed, making this angle greater, 20 degrees or greater of Q angle is actually indicative of structural malalignment. So this means that you're going to have a lot more forces going through the knees, and you're going to put your knees at a greater risk for injury and irritation, and specifically put you at a greater risk for patellofemoral pain syndrome. Another important aspect of alignment is how your kneecap is sitting on top of your femur. So a good analogy here is you can picture your patella, your kneecap, and your femur working together like a train on a track. Here your patella is the train, and it sits on top of the femur. And just like you would on a normal train track, you want the train to be perfectly centered on the track for function to be optimal. And if that patella is, say, not tracking correctly while you're bending your leg, doing a high impact activity, that can result in a lot of pain because there's going to be odd pressures, that patella's not staying in its groove. In the case that's instability, that kneecap can even pop out of the groove, resulting in some feelings of instability and subluxation. So the two other causes, or common causes of patellofemoral pain syndrome, are strength deficits and flexibility deficits. The big muscles that you prioritize strengthening here with physical therapy when it comes to treating patellofemoral pain syndrome are, first of all, your quadriceps. They function to extend your knee and hold your kneecap in its groove in place. You also have your hip abductors. That's the muscles that prevent your hip from dropping whenever you're running and walking. And the main muscle that we focus on in PT is the gluteus medius. The last important muscle group is your hip external rotators. Your gluteus maximus and your piriformis, that's the two big external rotators. They prevent your knee from collapsing inward. That's a term called valgus collapse, and keep the knee in a good position, especially with higher demanding activities. When it comes to flexibility deficits, the major muscles that you want to stretch a lot to make sure that you're optimizing the function around the knee. It includes the IT band, running down the side of the leg, your hamstrings, the muscle in the back, your quadriceps, and then your gastrocnemius. That's that big calf muscle that crosses the knee joint. So now we'll move on to the last cause of knee pain that's not really directly related to an injury. It can be, but it's not always directly related. We're going to talk about knee osteoarthritis, or OA. So arthritis is also known as degenerative joint disease. It results from the wear and tear on your joints that causes the gradual loss of your articular cartilage. So, excuse me, on the end of your bones of the femur and your tibia, two big bones in the leg, you have some cartilage there that helps them to glide smoothly on each other. And whenever that cartilage deteriorates, you end up with bone-on-bone contact. That's something people are commonly told whenever they're diagnosed with arthritis, that the cushion separating their bones is just not quite there anymore. It's, like I said, it's usually a result of just wear and tear over time. Some common symptoms you'll see with osteoarthritis include knee pain that onsets gradually and worsens with activity. You have knee stiffness and swelling, and then you have pain that worsens with periods of prolonged rest. Because that joint is already cranky, the cushion that used to sit in between is not really there whenever you rest for extended periods. The joint tends to get tightened up, and as soon as you go to move on that joint, it's going to hurt more. So that's usually manifested as morning stiffness. First time you stand up in the morning, more knee pain with arthritis. And I gathered a few facts about osteoarthritis that I think really shed light on just how big of an issue is and how common it is. More particularly, I looked up stats in the United States here. So osteoarthritis is the most common joint disorder in the United States. Symptomatic osteoarthritis occurs in about 10% of men and 13% of women that are age 60 or greater. So that's a really large percentage of our older folks. In 2015, the CDC estimated that about 24% of the U.S. population has been diagnosed with some form of arthritis by their medical doctor. And if you do the math, that adds up to be roughly 54 million people, so a whole lot of people diagnosed with arthritis. There are several risk factors for osteoarthritis. First one being obesity. There's something we really see commonly in our clinic, that our obese patients tend to also have arthritis, because the way you can think about it is that when you have excess weight, that's just more pressure going through the knee, puts more demand on the knee, and will cause that knee to kind of deteriorate more quickly over time. So I always recommend to our patients that are obese and have knee pain that they should take a holistic approach. Have a good diet, frequently exercise, and losing weight can only help to decrease their knee pain and prevent their arthritis from progressing as quickly. Some additional risk factors include older age. As you get older, you're more at risk for arthritis due to that wear and tear feature of it. Joint injury and overuse also puts you at a greater risk for developing arthritis. It's something we really see commonly in the clinic a lot, with more particularly like our military folks, because they tend to get more injuries. They're doing a lot of higher level activity and exercising. A lot of my guys will tell me they'll do 3-mile runs with 50-pound packs on their back, and you can only imagine the kind of pressure that's putting on your knees. And it gets to the point they put so much strain on their knees that they end up having arthritic changes in their knees that resemble, more, you expect to see more in like a 50 or 60-year-old, but they're just in their 30s. That's because of the high demand they put on their bodies being involved in the military. The last big risk factor I thought was very important to bring up was gender. Women are more likely to develop osteoarthritis, especially after the age of 50, and this is due to the loss of the protective effect of estrogen that you have, and you lose that after following menopause. So now I've summed up several of the common injuries that occur at the knee joint, kind of the mechanisms of injury, how they occur, and why they occur. I also talked about a few of the types of knee pain that result that aren't always due to direct injury. Now I'm going to talk about a few of the ways that we at physical therapy in general, how we treat knee pain, make it better and improve people's function. So here at Physical, we take a hands-on physical therapy approach where we're focusing on freeing up the joints in the knee as well as stretching the muscles in your knee to try to regain pain-free range of motion. Um, so what this will normally look like, if you come in and say you have some deficit, say your knee is not extending fully, not flexing fully, your therapist will do some manual stretching with you, focus on improving the flexibility of the muscles surrounding your knee, so mainly your quadriceps and your hamstrings. But they'll also do some joint mobilizations because you want both the muscles to be loose and free to move, as well as the joint itself. So manual stretching is a huge component here. Helps to really get good results and maximize how your knee is moving. We also will throw some strengthening exercises at our patients, focusing on improving the strength and stability of not just the muscles directly surrounding the knee, like your quads, hamstrings, things like that. We also want to focus on those muscles I addressed earlier, mainly being your hip abductors and your hip external rotators, those muscles that prevent your knee from collapsing into a precarious position, especially with the higher impact activities. In addition to that, we do some activity-specific training here to try to improve function and reduce the risk of both falls and re-injury. That can, be a variety of things. Say it's one of our older folks who's looking to walk in the mall without a walker. In the clinic here, we'll first work on improving his strength and stability of his core, his hips, his knees, improving his endurance, and then we'll actually practice, setting up in a harness system, preventing him from falling, and working on breaking away from using that walker, transitioning from walker to a cane, then learning to walk without the cane so that he can achieve his goals. That's an example of like one of our older folks and what we do with them regarding activity-specific training. And a lot of our younger folks or our military population, we can use the example of we have a military guy who wants to return to running. We'd start with some exercise on the mat to build his foundation, core, hip, and knee strengthening. Progress to standing exercises, and then after that, we would initiate something like a return to running protocol in which we're watching how he's running and modifying it appropriately. The last common treatment we use to address knee pain is passive modalities. This includes things like heat packs, ice packs. We'll occasionally use electrical stimulation if it's called for to decrease pain. And one thing I wanted to discuss too is that we use dry needling here. That's been something we found really effective, especially in our chronic pain, knee arthritis patients. That dry needling can really benefit them. If they feel like they're stuck, they had this pain for so long, they don't know what to do about it, you'd be surprised how quickly they can get better if you throw a few strengthening exercises at them, throw them the right stretches, and then use that dry needling to get that increased blood flow to the joint. We've even had several successes here where we've had those patients that come into the clinic to do their therapy prior to their total knee replacement, but we get them to a point where they have so little pain and they're functioning so well that they no longer need to get that surgery. So with that, we save them a lot of time, effort, money, and pain, because anytime you have surgery, there's going to be a lot of damage going in. They're going to repair the issue, but you're going to have a lot of pain after the surgery and during that recovery phase. So dry needling is something that we've really found to be helpful in our treatment of patients with knee pain. So to kind of sum things up today, there are many causes of knee pain, several of which I discussed in the presentation today. The main topics that I covered were ACL tears, meniscal tears, patellofemoral pain syndrome, and then knee osteoarthritis. However, there's also some topics that we didn't have time to cover, some really important diagnoses like bursitis, fractures, IT band syndrome, and there's several more, but I tried to just cover the most important ones that we commonly see and treat here. But it's important that we get a good understanding of all these diagnoses. And then if you do have knee pain, please see a physical therapist because they'll perform a comprehensive evaluation on you and create a personalized treatment plan to address the specific cause of your pain. Performing an appropriate progression of prescribed exercise with your physical therapist will help to decrease your pain, improve your overall function, prevent re-injury, and can even prevent you from having unnecessary surgical procedures like I talked about earlier, and preventing people or helping people to avoid a total knee replacement, something like that. And this is why it's important that you work with a physical therapist near you to address your knee pain sooner rather than later. So I also want to take this opportunity to just say that we are offering free screenings here at Physical. So if you yourself have knee pain or know anyone that has knee pain or has any of the issues similar to the things that we discussed today, please come on in. We're doing free consultations. They last roughly 20 to 30 minutes. It's where a physical therapist will take you into a room, kind of get a history from you, see what's going on, do some quick tests and measures, see if you're appropriate for physical therapy, which if you came to the clinic for this, it's a 99% chance you will be appropriate for physical therapy. And then we'll send a note to your doctor and get your treatment started much sooner rather than later. So free screens are available. Please take advantage. You can call us at the clinic, 504-861-4693, if you want to set that up. And I just wanted to say thank you guys for coming and listening, taking a minute out of your busy day to come hear me talk about knee pain. I hope some of the topics I discussed today are helpful. Maybe gave you a better idea of what exactly you're going through, how you can treat the knee pain, what you need to do to get better. If you have any questions, like I said, feel free to post there on the side in the comments or call us at the clinic and we can address those as soon as possible. But thank you guys again for tuning in. I hope you all have a great rest of your day.